Good morning, everyone. Today, our colleague Dr. Ala will talk to us about the clinical applications of MR spectroscopy. She can start. Go.
Good morning, everyone. My seminar is taken from a research, an article actually, under the name Clinical Proton Spectroscopy in Central Nervous System Disorder. That is published at 2014. All of my slides are taken from this article, apart from few slides for more clarification. All these names are the names of the participants in this article, and their information are taken from many data and studies. This article represents a summary of brain disorder in which MR spectroscopy has an impact on patients' management. And the clinical usefulness of MR spectroscopy has been established for brain neoplasm, neonatal and pediatric disorder, hypoxia, inherited metabolic disease, traumatic brain injury, demyelinating disease, and infectious brain lesions. We are not going to talk about the basics of MR spectroscopy, but it's good to revise together the position of the metabolites on a normal spectrum. This is a normal subject in which the spectrum has the box is put it on over the posterior occipital over the occipital region, and the spectrum shows the standard metabolites, which are NAA, creatine, and choline. NAA is assigned at 2.05, and this is a marker of neuronal and axonal viability. Creatine is the most stable metabolite and is assigned at 3.05. It is a marker of cellular metabolism. Choline is just beside it at 3.22, and is a marker for cellular proliferation, and it's a very important metabolite. Other metabolites are myoinositol at 3.56, and another peak for creatine is found here, with the glutamine and glutamate between creatine and NAA at 2.05 and 2.50. At this side, we have other important metabolites, which are lactate and lipid, with alanine here. Lactate and lipid are the region of 1.3, 1.33, and alanine here at about 1.4. In brain tumors, we all know the tumor spectrum, which is elevated choline along with decreased NAA, is typically regarded as diagnostic feature for brain tumor. The prominent signal from lipid associated with necrosis or hypoxia. Abscesses and tuberculoma show elevated amino acids and lipid. And we have another important metabolite in primitive neuroectodermal tumor is elevated. It's called taurine. And alanine in meningioma, glycine in high-grade pediatric tumors. And if biopsy is needed for diagnosis, of course you want to take the biopsy from this area of highest cell density, and you will put the spectrum over the area of with highest choline and NAA ratio will be the site for the biopsy. This is an example of posterior fossa tumor. First of all, you should determine if this tumor spectrum or not. It is an actual tumor spectrum, elevated choline, NA is absent, and with elevated lactate and lipid. But here, beside the choline, we have another extra peak that's elevated, which is the position for taurine. So you can more confidently say that give the differential for this tumor as the diagnosis for this tumor as medulloblastoma.
Being a peanut.
Peanut. Primitive neuroectodermal, yes. And an example of extraaxial tumor, combination of imaging with the spectrum. Again, this is a tumor spectrum, elevated choline and absent of NAA, and this is lactate having two peaks with lipid, but beside them there's alanine at its expected region, and this you can give the diagnosis of meningioma by a combination of spectrum and the imaging. Another important thing is to differentiate metastasis from peritumoral, from high-grade primary tumors. For example, high-grade gliomas. You will put the spectrum at around the tumor. In case of metastasis, there will be near normal spectrum in peritumoral region, whereas in high-grade glioma, it will be elevated, calling NAA ratio will be elevated, reflecting tumor invasiveness. And this is an example of low-grade, grade 2 astrocytoma and high-grade astrocytoma. Both are showing elevated choline and absence of NAA. But what's important is here elevated lactate, but here the peak for lactate and lipid is very high. In this case, the elevated lactate is due to hypoxia, but in this case, it should be due to necrosis because it's very high, so it can differentiate between the grades of astrocytoma. To determine the prognosis, choline NAA peak amplitude ratio of at least 2.1 was found prognostic of unfavorable outcome in pediatric diffuse pontine glioma. And if the ratio is more than 2.1, it's associated with poor prognosis.
Usually, should the NAA be more than the choline?
Yes.
If they are equal, it's abnormal,
Yes.
1 to 1.
Yes.
If the choline is twice the NAA, it's even worse.
Worse.
Okay? Because it means highly proliferative tumor.
For neurosurgical treatment planning, one study reported that MR spectra defined abnormal area was about 2.24% larger than that's delineated by T2 hyperintensity. And the size will be larger. And another study demonstrates increased myoinositol and glutamine level in contralateral hemisphere in those who are untreated glioblastoma multiforme, indicating a very aggressive tumor and early tumor infiltration.
So what we see in MRI, in routine MRI, it's around 24%, even more.
Larger, the size is larger.
It's larger, yeah.
And spatially correlating with histological type and grading, choline NAA ratio greater than 2 and lactate NAA ratio greater than 0.25 and the presence of lipid at MR spectroscopy imaging with a long TE are characteristic of high-grade tumor because normally lipid will not be seen with a long echo time. And recent intraoperative MR spectroscopy, they will do it with high Tesla, for example 3 Tesla, help differentiating tumor from non-tumoral abnormality as indicated by high choline creatine ratio and the presence of lactate. And also can avoid incorrect diagnosis of tumor progression. The choline creatine ratio was shown to reliably differentiate from between recurrent glioma and post-radiation injury, and this is a very important issue. As in this example, by imaging these two areas, they are both histologically proven. This is a case of recurrent glioblastoma multiforme, and this is a case of radiation injury. Here in both cases, there's elevated lipid and lactate, but here the choline creatine ratio is abnormal, it is elevated, but here the choline creatine ratio is normal. So by this, before the pathological diagnosis, you can decide.
Without spectroscopy, both of them look the same.
It is impossible. Yeah.
Impossible to differentiate. You can have no clue to differentiation. But with the spectroscopy, the elevated choline related to creatinine indicates high cellular membrane.
Yes.
A lot of cellular membrane. Okay, indicating it's a recurrence.
We should take from the periphery of the mass.
They are doing a multivoxel. You can see here.
Even in normal area.
Yeah.
In pediatric disorders, for example, Hypoxia-Ischemia, inherited metabolic and traumatic brain injury, they found its usefulness in these areas also. For a newborn infant, quantitative assessment of cerebral lactate due to hypoxia is one of the earliest imaging signs before the imaging become abnormal and before any imaging abnormality is seen. And the presence of high lactate is associated with poor outcome. MR spectroscopy can be used as a means to assess treatment efficacy of hypothermia, which are done in this patient, a proven neuroprotective treatment for perinatal asphyxia. Here we have a T2 weighted image of a newborn infant. I said this is T2. Anyone can tell me why the white matter is white? Normally white matter is dark.
Age of patient.
Yes, excellent. It's a neonate, the developing brain. It's unmyelinated white matter. And if you notice, there's myelination started at the posterior limb of internal capsule.
If you remember from the pediatric
in your imaging.
long time ago.
And this is done at the same day they suspected Hypoxia-Ischemia, and you see that there is no abnormality with the imaging. Here is the diffusion, showing no abnormality. Here's the spectrum at the same day. There's elevated choline creatine ratio, and we have normal NAA, but the lactate is also elevated, which is the choline here is normal. It's normal for neonate.
Because the neonate,
yes.
NAA is low.
NAA is a bit low, but choline to creatine is normally high in neonate. But what's important is the lactate. Lactate is elevated, which is the earliest imaging finding. Here, 10 days after the onset, they did MRI again. This is a T2-weighted image showing areas of hypo and hyperintensities, indicating ischemo-hemorrhagic areas. And this is the proton density image, clearly showing the extent of the lesion. MR spectral has proven clinically useful in neonates suspected of having metabolic disorders. The presence of pyruvate and succinate are early indicator of pyruvate succinate dehydrogenase complex deficiency. And also detection of elevated glycine, in particular at long TE, is clinical diagnostic in nonketotic hyperglycemia. A grossly elevated NAA level is diagnostic hallmark of Canavan disease. This is elevated glycine in patient with nonketotic hyperglycinemia. We have a metabolic disorder called creatine deficiency, which has 3 types. The first 2 types due to creatine synthesis defect. The last type is due to creatine transporter deficiency. They found that if they give creatine to this, the first 2 types, they will get a normal spectrum after the treatment.
But it is the synthetase deficiency.
But in
the synthesis is deficient. So if you give it to them,
they will be treated. But in transporter deficiency, they will they are not getting benefit from creatine therapy. Mm-hmm. So by spectroscopy, you can differentiate even these types. But in all 3 types, the creatine is low. But to differentiate between the types, type 1, 2, and 3, you can, after treatment, you can do another spectrum to see what is the type of the
so they give treatment and they do another imaging.
Yes.
If the creatine becomes normal, then it is a deficiency.
Synthesis deficiency.
If it does not become normal, it's transporter deficiency.
And if we have liver disease, it's regarded as transport deficiency?
I don't know. I really don't know.
This is a patient with creatine deficiency, and before treatment, you cannot see creatine peak at its position. This is choline, and this is NAA. After treatment, see the creatine is elevated, as clear, beside the choline with normal NAA, so it is either type 1 or 2. Minor imaging in a single or multiple metabolite required careful quantification of MR spectra and comparison with well-established normal value. And it means that you should compare each patient with a child of his age. And this is very challenging to find all these normal data, but it is particularly crucial because of the developmental change in metabolic level. And this is limitation of these studies in pediatric patients.
Because how many healthy children do MR spectroscopy?
Yes.
Diseased children are little. Healthy children are even less. Okay.
Traumatic brain injury is a major cause of disability and death among children younger than 14. Incorporating the age, of course, initial Glasgow Coma Scale and presence of retinal hemorrhage. Supplemented with NA, creatine ratio, and MR spectral with visible lactate within the first month after the incident was shown to differentiate between good and poor prognosis. Pediatric near-drowning accidents MR spectral index based on NAA, lactate, and combined glutamate and glutamine was shown to correctly differentiate between good and poor outcome with no false positive result.
No false positive?
Yes,
wow.
It's very important. In demyelinating diseases, MR spectros is used to monitor the onset of demyelination in neurologically asymptomatic patients. The patient should be asymptomatic and with X-linked adrenoleukodystrophy, high genotypic variability. They will do a follow-up of this patient with MR spectroscopy to detect the earliest onset of demyelination. so that they can decide whether they can do hematopoietic stem cell transplantation or it is not beneficial. If the imaging start to be abnormal, it will not be beneficial. So it is very beneficial in these patients.
If there is abnormal imaging, no need for stem cell transplant.
No, but if the spectrum is abnormal, there's still hope before the child gets neurological deficit. In patients who are newly diagnosed with juvenile or adult metachromatic leukodystrophy, a combination of MR imaging and MR spectroscopy can be used to judge the state of brain tissue inflammation. Again, in these patients, the aim is to decide for transplantation. Myoinositol is typically increased even in the early stages, and the detection of myoinositol is not a problem, but as long as the NA is still within the normal range, you can do the transplantation. This is a patient with adrenal leukodystrophy. You can see that there's abnormal signal within the posterior 1/3 of semi-ovale, and the spectrum had been put on the anterior third of the centrum semi-ovale, and you can see that the spectrum is normal. The choline, creatine, and NA is normal. And 1 year after, they did another imaging and another spectrum. The abnormal intensity extended to the middle third of the centrum semi-ovale, and the spectrum in the anterior third, in which there is no abnormality in the imaging, showed abnormality in the spectrum, in which there is elevated choline creatine ratio and NA started to decrease. And 2 years after the second imaging, it is extending all over the centrum semi-ovale by imaging, and the spectrum is further becomes abnormal.
See, it indicates progressive neuronal loss.
Yes.
NA is decreasing.
But what is important is that the image abnormality in the imaging didn't extend here, but it showed abnormality before the imaging. This to prove that otherwise this patient gets no benefit from transplant. And the clinical use of MR spectros in multiple sclerosis, it is limited. It shows some benefits, but it's not that beneficial. Chronic plaques show a consistently reduced NAA creatine ratio and sometimes elevated choline creatine ratio. Plaques undergoing active inflammation show an elevated choline creatine ratio, normal or reduced NAA creatine ratio. The choline creatine ratio is elevated in normal appearing white matter months before lesions become detectable at conventional MR imaging, with acute disseminated encephalomyelitis showing recovery of NAA signal loss as a favorable prognostic sign. Focal lesion caused by infectious agents. We have pyogenic abscess and parasitic cystis and tuberculous abscess. In cases of pyogenic abscess, we have elevated succinate, acetate, alanine. In parasitic cystis, succinate and acetate will be elevated, and tuberculous abscess will show lactate and lipid elevation. This is the case of pyogenic abscess. By imaging, we have the 2-weighted image. It shows a focal area of abnormal hyperintensity with a hypointense wall, and T1 weighted image, hypointense lesion with isointense wall. By diffusion, there's restriction, and by contrast enhanced imaging show ring enhancement, and the spectrum shows succinate and acetate, so it is a pyogenic abscess. Acetate elevated with, of course, lipid and lactate, we said. Yes, this is the...
There is no loss of
NAA should be here, it is lost.
It's an abscess.
NA should be here, it is lost. And choline should be here, and creatine beside it. But
There
this
is no
abnormal...
neurogenic tissue at all. So it will be absent.
In neurodegenerative diseases, the characteristic feature of neurodegenerative disease at MR spectrum is a decrease in NAA, typically localized to the region affected by degenerative process. Constantly, NAA creatine ratio tend to be lower in subjects with mild cognitive impairment who convert to dementia compared to those who remain stable. Therefore, the NAA creatine ratio or NAA concentration may be a valuable prognostic indicator of disease progression. MR spectroscopy changes associated with neurodegeneration include a decrease in glutamate, elevated choline, and elevated myoinositol. The elevation in myoinositol may be associated with glial or microglial activation, which is a characteristic feature of this disease. An elevated myoinositol level appear early in dementia, preceding the decrease in NAA. And in dementia, myoinositol is more diagnostic. This is a case of post-mortem pathological diagnosis of Alzheimer. They put the spectrum over the posterior cingulate gyrus. This is a control patient, shows normal spectrum. This patient with mild cognitive impairment. The NAA is still normal, but myoinositol is elevated. Yes. In this case, this Alzheimer patient shows further increase in myoinositol with decrease in NAA. In cases of epilepsy, abnormality in NAA concentration and that NAA creatine ratio have been useful for detecting injured brain in seizure onset in the seizure onset focus. MR spectroscopy imaging measures have also been extended to neurotransmitter, for example, to assessing gamma aminobutyric acid in patients with epilepsy at ultra-high field strength. In acute stroke and brain ischemia, preclinical work has shown that NAA decrease in ischemic brain parenchyma in a linear fashion for the first 6 hours, followed by a slower decrease for the subsequent 24 hours. A decrease in NAA on follow-up MR spectroscopy data has been associated with ongoing ischemia and progressing infarction. Lactate is another metabolite with potential value for clinical evaluation in stroke. Elevated lactate in the core of ischemic tissue correlates with the final infarct size and the clinical outcome of the patient.
So you can see it's not just 6 hours to save a brain, it's up to 24 hours. The lactate is decreasing.
Yes.
Yeah, you can't save it after 12 hours. You can't save something.
Thank you.
Thank you very much. Thank you. It was very, very nice. I liked it. Any questions? Anybody understand anything?
لا مو كلنا نحبها بس اخذنا معلومات زينه.
Yeah, it's amazing. I liked it.